Hello everyone, welcome to Osteoporosis Canada's Fracture Liaison webinar. It's 12:58 by my time, so we'll give everyone a couple more minutes and then we'll get started. So I'd like to thank everyone for joining us with Osteoporosis Canada and the Fracture Liaison Service webinar today. Today we're going to hear from Dr. Suzanne Morin, and she's going to talk to us on osteoporotic fractures and the care gap. So as we get started and people are joining, just please let me know if you're having any difficulties hearing. You can send us a message in the chat box and we will try to address it. Also, if you can see but not hear, you have the option as well of joining in by calling in on the phone number, and that's just above under your audio that you can click and you'll see a phone icon, so click on that and you'll get a number. Also, at the end of the presentation, we hope to have some time to take your questions. So again, you can put your questions into the question box at the bottom, and I will read them to Dr. Morin, and she will try and find time to answer them. If we run out of time, there's also a survey that will be sent to you at the conclusion of the webinar, and it provides you both an opportunity to provide to us some feedback on the webinar and the technology we've used, and also a chance to put a question in, and I will be sure to try and get those answered for you. As well, if you haven't looked at our FLS Hub website, which is nested within the Osteoporosis Canada website, I invite you to do that. The website address is on the screen in front of you, and it's in the blue, so you can visit that. And it has a wealth of information on that site that includes the FLS toolkit, the registry that lists the FLS sites that are active in Canada. We have a network that allows you to be part of our liaison newsletter. We also will consult with you to let you ask questions about implementing an FLS. We have the webinar series such as today, and we try to do most of those resources in French as well. So before we get started, I'm going to share with you Dr. Morin's bio, and then she will take over and you'll learn from her. So Dr. Morin graduated from the Faculty of Medicine at Université Laval de Quebec. She did her internal medicine specialty training and obtained a master's in epidemiology and biostatistics from McGill University, where she is now an associate professor in the Department of Medicine in the Division of General Internal Medicine and a scientist at the Center for Outcomes Research and Evaluation of the Research Institute of the McGill University Health Center. She is the co-director of the Clinical Scholar Program for the General Internal Medicine Training Program. Dr. Morin's research program includes evaluation of outcomes of osteoporosis and its treatment, and implementation of health system improvement initiatives for patients who have sustained fractures, such as secondary fracture prevention, pain management, and functional recovery. She also studies the pathogenesis of bisphosphonate-associated atypical femur fractures and safety of calcium supplements on vascular health in postmenopausal women. She is a leader in clinical practice guidelines development for the management and prevention of osteoporosis and fractures. She is a scholar from the Fonds de Recherche de Québec à Santé and has received funding from the Canadian Institutes of Health Research and other peer-reviewed agencies. Since 2018, she is the past chair of the Scientific Advisory Council of Osteoporosis Canada and a member of the Council of Scientific Advisors of the International Osteoporosis Foundation. It's my pleasure to welcome you, Dr. Morin, and thank you for sharing your knowledge with us today.
Thank you very much. There we go. So thank you. So I assume everybody can see my screen, and thank you for the kind introduction. So today what I'm hoping to share with you and what I was asked to talk about is actually the care gap in osteoporosis fractures across the country. And I will be going through some information that will help us understand better this gap and potentially how we can improve upon it. So my disclosures are as follows. And the objective, as I've just said, we will talk about the epidemiology of fractures, the care gap, and hopefully we'll have some time for discussion on how to implement evidence-based strategies such as fracture liaison services to help identify and manage these patients at highest risk for fractures. This is just briefly, I know I'm speaking to the choir, but I always use this slide to remind everybody that osteoporosis is not only about bone mineral density. Although this is what we measure in clinical practice, bone strength is much more than that. And I think we still have a lot of education to do in order to impart this particular concept that bone strength is also about bone quality and bone geometry. Bone geometry is something that we don't have much of an impact on, but we certainly have the ability to impact on bone quality either through ensuring proper nutrition, vitamin D sufficiency, exercise, so that we continue to enhance better bone quality throughout the life cycle. Bone strength is influenced obviously by biomechanical loading, biological factors, as well as genetic factors. And so often, and this is some of our challenge, is that both patient and primary care providers and other healthcare professionals equate bone density to bone strength, and will, in the setting of a not osteoporotic bone density, the ability to consider other important factors that reflect bone quality is not put forward, which is part of our, as I said before, our challenge. So here I show some data from the Canadian Public Health Agency, looking at fractures across age groups, both in men and women. As we know, men tend to have a lesser number of fractures than women, and often tend to have fractures at a later time in the lifespan, so their fracture rates tend to increase in the age of 75 and older, whereas in women around menopause, you start immediately seeing an increase in fractures, particularly of the wrist. In both groups, in the elderly, hip fractures become obviously the fracture that is more frequent, and also, as we know, that has the most serious consequence. As we all know, fractures cause excess mortality, as well as a factor for subsequent fractures, pain, decreased mobility and autonomy, and of course are associated with increasing cost over the entire jurisdiction. Mortality is often thought to be secondary mostly to hip fracture, but in this administrative data study from Manitoba, we looked at the mortality following a fracture in the first year following the fracture. And we documented that indeed hip and spine fractures are the ones that are most associated with increased mortality in women. But if you look in men, other sites such as the humerus is also associated with an increased risk of mortality. And this is because men tend to have more comorbidities at the time of their fracture, which of course can complicate the hospital stay and thereafter has an effect on their mortality. So it's important not to just talk about the hip fracture when we are mentioning negative clinical outcomes, but also spine, humerus fracture are of importance. When we talk about subsequent fracture, it's also, again, here important to see the difference between what happens to men and women. And in men, we know, so this is looking to orient you, this is at a graph looking at the risk of subsequent major osteoporotic fractures, so those of the hip, the spine, the humerus, and the wrist, after having sustained an initial fracture, and looking at time after this fracture. And so what we see here is that the risk of having a subsequent fracture is elevated, both in men and in women who have sustained a fracture compared to those who have never sustained one. However, that risk of subsequent fracture is much higher in men for the first 3 to 8 years or so compared to women. Again, this reflects the fact that men tend to have more comorbidities at the time of fracture, which put them maybe at higher risk for falling and at higher risk for having subsequent fracture. So once you have one fracture, as we know, the risk of having subsequent one is elevated, but the imminent risk of having subsequent is higher in men than it is in women, making it more imperative to continue paying a lot of attention to men. Now I'm going to shift to screening, prevention, and management.
Dr. Moran, can you check your mic and make sure that
Screening, it's fine, my mic?
Yes, you're good now, thank you.
Thank you, okay. Screening as well as prevention and management. So there were specific questions that they asked the participant, and here we're only looking at people who are 40 years and older. And so they asked the participant whether a doctor had ever told them if they had osteoporosis. And if yes, then they asked them if they ever had a fracture of these bones that you see there. And if no, again, they asked them about that same question. And they then divided the participants into 4 categories: those who had both osteoporosis and a fracture, those who had only osteoporosis, those who had fracture but not a diagnosis of osteoporosis, and then the category where they had neither. And I apologize for the small font, but I think what I would like to then bring your attention to. So then they looked at whether people had, they asked them, have you ever had a bone density test? Do you take vitamin D supplement? Do you take calcium supplement? Do you exercise? And do you take osteoporosis medication? And so then by looking across in these different categories that I mentioned to you, what you will see in those who've had a diagnosis of both osteoporosis and major fracture, both men and women, although less often in men, but both men and women tended to have undergone a bone density, tended to take vitamin D supplement, calcium supplement, and the exercise, as you'll see, is kind of low uptake in everybody. But the osteoporosis medication definitely were in the women were more important than the other categories. However, NR usually mean that they are not able to report because there's not enough participants in those cells. However, if we look at people who have had a major osteoporotic fracture, and this brings us back, of course, to the importance of identifying patients at high risk, you will note that if the participant had not reported the diagnosis of osteoporosis, they were less likely to have undergone a bone density, to take vitamin D supplement or calcium supplement, and there was no indication of osteoporosis medication intake. So again, just to the point I was making before, the bone mineral density is often, or trumps often, the history of fractures. Again, we're looking at the same data, but stratified a different way. What they are looking at here is the factors that were associated with the use of osteoporosis screening, prevention, or management. And so I just want to highlight here two important points. So the older the participant, the more likely they were to undergo a bone density, take vitamin D, take calcium, and take medication, although this was not significantly significant. If they were men, you could see that they were less likely to undergo any of these strategies. And if we go down here, if people had a major osteoporotic fracture, they had no more they were not more likely to have a bone density, to take a vitamin D, calcium, or medication. None of these were significantly different. So this is important, and again, just highlighting what I just said before. In a different study, looking with Bill Leslie again, and looking at the Manitoba database, we looked at people who are, these are women now, and we're looking at treatment, osteoporosis treatment initiation in people who have all had a prior vertebral fracture or hip fracture or multiple non-vertebral non-hip fractures. So these people would be considered by Canadian guidelines to be in the high risk category. Now, if you stratify these people by bone mineral density result, if they have a normal bone density, even though the green bar is the high risk fracture patient, even though they have a significant high risk for subsequent fracture, if their bone density is normal, they're unlikely to receive osteoporosis medication. If they have low bone density but no osteoporosis, again, they're more likelier to receive anti-osteoporosis medication. And finally, yes, those at high risk do receive medication, but not more than those who have osteoporosis on a BMD. Again, showing that the BMD is something that is felt by the clinicians to be of extreme importance. So now we're going to change topic and move on to the osteoporosis treatment rates, or the treatment gap that we have in Canada. So as we know, it's been noted that osteoporosis treatment rates have been declining. Fracture liaison services have been instituted in many jurisdictions. However, even if these programs are associated with improved outcomes, there's been a high proportion of individuals who continue to not receive the appropriate osteoporosis screening or treatments that have been demonstrated to be cost effective. So what I'm going to show you now is using data that we have been, that through PHAC and the Osteoporosis Surveillance Group have been able to look at. We're going to describe the secular trends, or the change over time, in post-fracture care in Canada from 2000 to 2015 in people who are age 40 years and older. And what we're going to look at are kind of outcomes. We're going to be looking at those who receive a new osteoporosis diagnosis. So they didn't have an osteoporosis diagnosis prior to this fracture, and we're looking if they have a new one, if they've received a new BMD test, meaning that they haven't had a BMD prior to the fracture, but we're looking to see that they have one after this fracture, so screening. And we're looking to see if they have new osteoporosis medication. So we're not looking at people who are already on medication, but this is new osteoporosis medication within 12 months following a fracture at any of these sites. The data set that we use is a data that's called the Canadian Chronic Disease Surveillance System, where PHAC actually has access through various collaborations to administrative data from from provinces and territories, and these data are link together through various systems and allow for the evaluation of the outcomes that I've just mentioned we will look at. So I've discussed this already, but so let's go on to the results. So here we are looking at over time from 2000 to 2015, and we're looking at the percentage of patients who receive a new osteoporosis diagnosis in their medical record 1 year following an osteoporotic fracture at the sites I mentioned. So what you could see is that over time, this new diagnosis of osteoporosis did improve slightly, but not markedly, and basically up to 18% of women, but only 9% of men receive a new osteoporosis diagnosis after this major osteoporotic fracture. So kind of identification as osteoporosis. So, you know, you can argue that the physicians do not put in the osteoporosis diagnosis. It doesn't mean that they don't know or think the patient has it, but it certainly does not get recorded as being as such. If we look at those who have a bone mineral density test in the year following the fracture, we could see that these numbers remain below 10% in women and below 5% in men. It did improve in men slightly over the period. Well, maybe they don't need a bone mineral density because we know that this is a major osteoporotic fracture. And so to make the diagnosis or to decide on treatment, you don't necessarily need a bone mineral density. But there is some information and some data that support the fact that it's probably useful to do a bone density, certainly to monitor treatment if you're going to do this. So again, numbers that remain quite low. If we look now at the percentage of women and men who receive anti-osteoporosis therapy after in the year following that fracture, you could see that there was an increase in treatment from 2000 to 2009, up to 26% in women and 16 or almost 17% in men. However, since then, since 2009, there's been a slow but progressive and significant decline in these treatment rates, similar to what has been seen and documented in the US as well as in Denmark. If we look at the same data, so this is osteoporosis diagnosis, bone mineral density test, or osteoporosis prescription. We're looking at both men and women, so all these curves are now onto one graph. And the medication, and so we're looking at age groups here. So as expected, the older population receives more attention. We only have medication information as of the age of 65 in most provinces, which is why the osteoporosis medication curves only start at 65. But as you see, the treatment rates increase till the age of about 80 years old, plateau, and then start to come down in the older patients, which is what we also see in clinical practice. Of course, there are contraindications to treatment, but the highest treatment rate is 25% of participants in women, and approximately just below 20% in men. You could see that bone mineral density test comes down after the age of 65, and in the very elderly, there's very few, and that arguably could be appropriate if only for, I suppose, diagnosis purposes. I just wanted to show you here that in the States, contrary to Canada, so in the States there seems to have been a plateau in hip fracture rates, or even maybe a slight increase in the last years. However, in Canada, and this is data that goes to 2012, but we do have data that goes on further, there's still a slight decline in hip fracture rates, and we have not seen this increase or plateau as they see in the as they've seen in the US. So for now, still a slight decrease, although certainly not as impressive as it was from 2000 to 2007 or so. Just to show some kind of other data separately, so Quebec Data, similarly, this is the same kind of information. We're looking again over time, 2000 to 2016. This is treatment rate, so one medication following a fracture in individuals, and you can see that over time there's been a slight decrease. There's also a decrease in the so here we go for these are the fractures. The major osteoporotic fractures, there's been also a slight decrease, mostly driven by fractures of the hip. The hospitalization for fractures remain low, and we know that these are usually associated with hip fracture, and they tend to mirror the number of fractures at major osteoporotic site that we see. And this is the diagnosis of osteoporosis, which has also been somewhat reduced. Bone mineral density has this kind of funny curve. We're not really sure why. Sometimes we initially thought maybe because of changes in billing codes, but it hasn't proven to be so. We can't really explain very well, except that there were guidelines that were published, as you know, in Canada around 2010, but the increase was seen prior to that. So this is somewhat confirmatory to what was seen over the country. So if you look at one fiscal year, which is the last fiscal year that we studied with the Canadian data, so we noted in the Canadian over the age of 40, 136,000 fractures. And of these people with fractures, 9% of men and 18% of women received a new diagnosis of osteoporosis. 5% of men and 9% of women received a new bone mineral density, and 13% of men and 22% of women received medication. But these were over the age of 65. So this obviously leads us to also trying to see how we could better harness patient engagement into not only for their own bone health and self-management benefit, but also to try to understand better how we can transfer this information of this fracture being important, but recurrent fracture. So this is a survey that we did looking at the Canadian Osteoporosis Patient Network members who, as you know, osteoporosis, Canada has this network of 10,000 members of this virtual network, whereby they receive every 2 weeks to every month a newsletter about osteoporosis, bone health, and how to live with osteoporosis. And there's all kinds of information and activities, in fact, that they can receive. We, as you know, at Osteoporosis Canada are working on our new clinical guidelines, and we wanted to make sure that our messaging of the guidelines would also resonate with patients, but we also wanted to know what patients felt would be important to include into the guidelines and what research questions were important to be asked. So this is just so we had 1,108 participants who answered our survey, which we thought it's a 16% response rate, but in this type of population, we thought this was actually quite good. You see the distribution of the participants, and this distribution actually reflects the overall membership of COPN across the country. And you see that most people said they had osteoporosis and that their knowledge level was average. So what I want to show you, I skipped, here it is. What I want to show you is actually what patients felt were important to consider in terms of outcomes for the guidelines. So although they did respond that it would be important to avoid future fractures, if you look at their main concern, people felt that it was extremely important to have recommendation about physical activity, fall prevention strategies, nutrition. And so here there is no mention per se of making sure that they receive medication for osteoporosis to prevent future fracture. I'm not showing you all the questions we had, but this here we felt was extremely telling, in that people are also very interested in being empowered with other issues than just medication. And this, I think, we need to pay attention to, or more attention to, in how we message this. Also, outcomes critical to consider. Of course, people are wanting to prevent fractures related to osteoporosis, but they're mostly interested in preserving their quality of life, death, and admission to long-term care. So again, when we discuss the importance of preventing secondary fractures after a first one, we need to also pay attention. We transmit this message that by preventing fracture, we may also impact on these other clinical outcomes that the patients feel are extremely important. And so, as we know, there's been a lot more interest now in paying attention to not only bone health, but bone health in the setting or in combination with joint and muscle mass. And these are concepts now that have been obviously better understood over time, and that when we see patients, we should probably address not only the bone, but also discuss their ability to maintain their muscular system in great shape, as well as addressing potentially their joint system. And because these are now all interacting, and if you have a decrease in bone and muscle mass, then you have osteosarcopenia, which would lead to more falls and potentially fragility fractures and loss of autonomy. So this is just to say that although, we spend a lot of time talking about bone, it is just as important, I think, that we talk about muscle health, as it has just as an important impact on bone health. And this is my last slide. So we all hear about high value care now, and how we need to pay attention to ensure that we provide interventions that will lead, hopefully, to better clinical outcomes without causing serious harm or even significant harm. And so we all know that the current evidence strongly supports the treatment of individuals at high risk for fractures. There's also evidence that is emergent that monitoring bone mineral density actually is effective in guiding therapy, but has to be understood in the setting of the global risk assessment, as opposed to just a diagnostic threshold, as I've showed you before. And patient engagement, I feel, is key in successful management, and probably should be harnessed even more so, to ensure that both the patient is more self-empowered, but also that the clinicians understand what patients feel is critical in the management of their bone health. And just here for those who are not aware, as we're working on, and I've mentioned this, Canadian guidelines for osteoporosis management, and hopefully we will be on track to release them in early 2020. And I will leave you with this. I was just recently at the International Osteoporosis Foundation meeting in Paris, and this artist had a few of these funny posters to show about, and there are many more of them, and I believe they will be available on the IOF website. So if you're interested, then you can find them there. And I thank you for your attention.
Thank you, Dr. Morin, and thank you for giving us a perspective of including the patients and the evidence in your presentation. So we are just going to give everyone a few minutes, seconds to send us off a question. And as I noted, you will get a survey after this. And in that survey, you can also put a question. So if you get missed or if you don't have time to put a question right now, then please do put it in that survey and send it along, and we'll do our best to get it answered. So the artist has got a good insight into osteoporosis and the testing associated with it. Okay, Dr. Morin, do you have any final thoughts, or shall we close it down?
Yeah, I think we could close it down. If people have questions, my email is there, so I'm happy to take questions after if they want. If the participants, have secondary questions that come later. And so I thank you actually for giving me the opportunity to present this information. I think it's very important, and that we now have a benchmark to go by, and hopefully we can improve upon it.
Thank you very much. And we will have this webinar archived on our FLS Hub website within about 10 days, so you can feel free to share it with others and watch it again. Thank you, Dr. Morin.
Take care.
Bye-bye. Thanks. Bye-bye.